So good afternoon to you all. And again, Manos, thank you for the kind invitation. It's always a pleasure to be here back in Athens and enjoy the rest of the meeting. These are my disclosures. So the topic here today is the new role of the long biceps in the treatment of large rotator cuff tears. Well, this is a report from over 50 years ago in which the intra-articular portion of the long biceps was used to cover the defect of this large cuff tear. A couple of years later, this author also described and suggested using the proximal attached long biceps as a pedicle graft, assuming that it would give additional blood supply to the construct, so probably enhancing the healing of the construct. So probably something similar to the superior capsule reconstruction, but maybe with a different rationale by then. So this is kind of what you can do with the long biceps for this purpose. So if you get inside the joint and check and confirm the irreparability of the cuff tear, you can cut the distal end of the biceps and fix it to the greater tuberosity and have this effect similar to the superior capsular reconstruction, but with an autograft, the long biceps. But is the biceps really effective for this purpose? Well, these authors tried to study on that and compare it to using a dermal allograft. And they found that the clinical scores actually improved in both groups, probably with an elevation that was better with the usage of allografts, but fewer complications when using the biceps. The allograft showed a failure and complication rate that was not negligible, around 35%, with more revisions and a poorer healing. But they did not study and compare it to the fasciolata, but these authors did. And when comparing partial repair of the cuff tear with the long biceps as a superior capsule reconstruction with the long biceps compared to using fasciolata in the superior capsule reconstruction, they found that the pain and function significantly improved in both groups, but the scores, range of motion, acromiohumeral distance were better with the partial repair of the cuff along with the superior capsule reconstruction with the biceps, although these results were not significant, this difference. These authors tried to check on the same aspects laboratorially, and they compared on cadaver specimens using long biceps and the fasciolata, and they concluded that using the long biceps was biomechanically equivalent or even stronger than when using fasciolata. But, however, in this study, the construct was a V-shaped construct, not a single-stranded, like I showed before in that video. And apparently the fasciolata is just this slim slice, not necessarily thick enough as one would expect from using it as a graft, but still valuable information from here. Likewise, these authors in cadaveric specimens addressed the same subject, and they concluded that regardless of the type of fixation of the biceps as an SCR construct, they got an increased mean maximum humeral abduction and a decreased humeral head translation, deltoid force that was needed, and the subacromial contact pressure that was lower, regardless of the type of fixation. Still, the V-shaped kind of construct seemed superior than using just a single-stranded, like in the video before, or when using a box-shaped technique. They also stated that when using a biceps that should be thicker than a dermal allograft, you may actually be contributing to that spacer effect that's expectable from an SCR technique. So this is one way of using the long biceps for this purpose, not necessarily an irreparable cuff tear, but still we're talking about a cuff tear. Oftentimes we see cuff tissue that is not strong enough and it's very slim. So if you leave the tendon attached to its glenoid origin and then cut it distally, you can use this stump to reinforce the construct and use it as an SCR. Likewise, similar case, you have the tendon stump already tack stitched with some sutures passing through the cuff tissue, and then fixing it with a lateral row knotless anchor in the greater tuberosity. And again, reinforcement of the construct, this SCR type kind of fixation. And as you go inside you can see the long biceps working as an SCR and the closed cuff tear. Likewise, in larger tears, see the long biceps attached to the greater tuberosity, working as a SCR, and then attached to the remains of the infraspinatus and the partial repair of the cuff. So this is probably one of the most common usages I have for this SCR with the long biceps, because it actually enhances the strength of the construct, and it's been shown that it also diminishes the risks of re-tear of the infraspinatus, so it protects the partial rupture, the partial suture. Now, coming back to the bridging and interposing the long biceps in the gap between the tendon and the bone, well, that's been reported in several occasions. Long ago, these authors reported on the open and arthroscopic repair of this kind, and they showed complete healing on imaging in 9 out of 14 cases with clinical improvement and comparable to conventional repair. So this is actually an option, and that's been shown several times. So this is just an example of what you can have. So you get inside the joint, you confirm the irreparability of that cuff tear, and you can reinforce it and interpose with long biceps. So as you can see in the middle picture, so it's been cut tenotomized from its origin. You got the sutures from the anchors passing through the tendon, incorporating the long biceps tendon stump, and then close the gap, finish the construct, and you have this reinforcement with the long biceps. These authors compared this technique with the usage of dermal allograft, and they found that the range of motion and function scores had improved significantly when using the long biceps, and only the VA score was improved when using a dermal allograft. Now, still, the failure rate was not negligible. It did exist, but it seemed better when used the biceps when compared to the dermal allograft. And however, when studying on the options of grafts you can use for this interposition techniques, these authors did this systematic review on all the grafts available, and they found that they actually work. They may be better than just simple plain partial repair of the cuff, but they found that on reports, allograft and xenograft seem to work better, perform better, namely in terms of function, graft survival on imaging, and due to the fact that there's no morbidity on the harvesting site. And when it comes to autograft, findings seem to support that fascia lata may work better than the long biceps. Now, in this book, in ESA, we tried to give an overview of all the options we have available to treat these conditions. And on these 3 chapters, a lot of things were written on this topic. And it seems that clearly there's still a lack of evidence that allows one to have proper recommendations or guidelines for the treatment of this pathology. However, there's definitely a role for the long biceps, and it should be considered in this setting of massive irreparable cuff tears. It provides you with a local graft, so no morbidity from the harvesting site. It would provide biological reconstruction and enhance the healing, with less tension and mobilization of the rotator cuff. Furthermore, when doing a tenotomy, you may be contributing to less pain that was originated by this tendon. And there's a lower cost associated to it because there are less implants being used. There are no synthetic dermal allografts from companies, so costs are lower. That's also appealing, of course. And the long biceps can act as an SCR. It can diminish the rate of re-tear when along with a partial repair of the infraspinatus, namely, and it can act as a sling for mobile tears, a bridge for immobile tears, as an augmentation for partially repairable tears, as shown. And it looks like there are still no clear guidelines for an appropriate management of these massive rotator cuff repairs due to a lack of high-quality evidence in the literature. So it seems that indications today are still largely based on personal experience and also extrapolated scientific data. Thank you.